meeting of the board to order. Will the secretary please call the roll?
Director Bott?
Present.
Director Curry?
Present.
Vice Chair Deere? Is absent. Director Garza?
Present.
I believe is remote. Director Harrington?
Present.
Director Ryder?
Here.
Director Robinson?
Present.
Director Sorrell? Present. Director Webster Cross?
Present.
I believe is remote. And Chair Taylor?
Present.
You have a quorum.
Thank you. The next regular meeting of the board will be held on Friday, April 26th at 9 a.m. I believe we do have some remote. They just probably weren't pleased. So I'd like to entertain a motion to allow Directors Raul Garza and Mia Webster Cross to participate remotely in this meeting.
So moved. Second.
Motion has been made and seconded. Is there any discussion? All in favor?
Aye.
Aye. All opposed? Thank you. The ayes have it. The motion carries. The first item on today's agenda is employee recognition, which will be reviewed by Dr. Verkaiser. Thank you.
Thank you, Chair Taylor. Good morning, directors. As always, we'll start by welcoming some of our new team members. Craig Leonard, Director of Respiratory Safety. Zenia Valdez, RN Coordinator, Bed Management. LaShonda Cox, Manager of Clinical Operations, Multi-Specialty Practice, Heart and Vascular Clinic. Yolanda Barner-Gerard, Manager of Operations, Multi-Specialty Practice, Sangstack Specialty Clinic. Daniel Barcelona, Manager of Vendor Management, Patient Financial Services, Managed Care. Lisa Gugler, Project Manager, Health Plan Services. Obed Asante Ofori, Manager of Inventory Control, Public Health Emergency Preparedness and Response. Diana Garcia, Senior Project Manager, Center for Health Equity and Innovation. And Anthony D. Beatty, Hospital Security Officer 3. Next, we'll congratulate some of our existing team members who earned promotions, starting with Chris Caudle, our Chief Medical Information Officer, HIS. Anshu Singh, Chair of the Division Postgraduate Medicine. Amy O'Rourke, Director of Chronic Disease Prevention. Peter Algindi, Residency Program Director, Anesthesia. Carlos Quezada Gomez, Senior Behavioral Health Officer. Riyad Haddad, Informatics Manager, Clinical Services, County Care. Dixie Dominguez, Residency Program Manager, Postgraduate Medicine. And Susie Cherian, Nurse Coordinator 2, Critical Care, Medical ICU. Welcome and congratulations to the entire team. We'll shift to recognitions now. Very excited about this one. This is our Behavioral Health Grant Program. On March 6th, we announced an open call for $44 million in grants through our Stronger Together, Building a More Equitable Behavioral Health System in Cook County. This initiative is going to focus on expanding and creating a tighter safety net for behavioral health needs, including prevention, treatment, support, recovery, and crisis assessment and care. The call is now open, and we're accepting proposals through April 7th at 5 p.m. Very exciting, and congratulations to our Stroger surgery team who performed the first robotic-assisted surgery on Friday, March 1st. It was a big step for the team.
Here. Yes, yay.
And thank you for taking the initiative to stand. My apologies. If you are mentioned, please stand to be recognized. Sorry about that. But yeah, so we have 2 surgical robots that were recently installed at Stroger. It's allowing us to provide gold standard surgical services. So again, congratulations to the team, and we'll be doing a ribbon cutting later in April.
Are we invited?
Sure. I'd love to have you. We want to recognize 2 of our Daisy Award winners, Ms. Bridget Sumo and Ms. Martia Brown. Ms. Sumo was nominated for going above and beyond in her care for patients undergoing chemotherapy. She's often praised for going the extra mile, answering patient and family concerns while coordinating care. And Ms. Brown has been with us for 30 years and was recognized through 18 nominations by patients, patient families, and her coworkers. They all highlighted her mentorship, her compassion, and her caring skills. So congratulations and thank you to you both. Next, we want to recognize our ACHN team for the primary care medical home structure. They achieved the Silver Target BP recognition from the American Medical Association and the American Heart Association for their commitment in improving blood pressure control for our adult patients. Congratulations, team.
Well done. Well done.
Great celebration for this. We had our colon cancer screening education fair at Stroger and Providence. In total, the teams educated 366 people about preventative measures and the importance of screening. Congratulations and thank you to those who made this possible.
Yes.
And next, we have 3 new graduates of the American Essential Hospital Fellowship. Dr. Priscilla Augustine Ware, Dr. Umair Jabbar, and Alexandra Normington completed the program earlier this month. The program's focused around empowering the participants with necessary skills to lead strategically and advocate for policies and resources that promote the health of vulnerable patients. The capstone project focused on care coordination for justice involved patients. Well done.
Thank you. Congratulations.
And last but certainly not least, our own Angela O'Banion was recognized as the Burroughs Legacy Award recipient. This is an award given by the Women's Board of the DuSable Black History Museum and Education Center, and it highlights leaders who advocate for diversity, equity, and inclusion. Award presentations will be taking place tomorrow, actually. Congratulations, Angela.
Congratulations.
Just keep rolling.
No, okay. All right. Yes. Thank you very much. The next item is public testimony. As a reminder, written testimony will not be read into the record, but will be included in the official record of this meeting and posted to the website. Madam Secretary, do we have any speakers who registered to provide in-person or virtual oral testimony or submitted written testimony?
We do. Before I call them to begin speaking, Director Garza wanted to check his microphone. He did hear us, but we didn't hear him. Director Garza, can you hear us?
I can. Can you hear me?
We see you.
Hi, can you hear me?
Well, we see your circle.
It looks like
Can you hear me?
you are trying to speak, but we do not hear anything. I will check with you outside of the meeting, and maybe we can have you log off and log back in.
Okay, can you hear me?
Okay. The first speaker is Michelle Gutierrez-Bow. And just a reminder, each speaker has 3 minutes, and when you get to about 2 minutes 30, I'll give you a heads up.
Please.
All right, good morning, everyone. My name is Michelle Gutierrez-Bow. I am one of the presidents-elect, well, the president for California Nurses Association and National Nurses Organizing Committee. We do represent the Cook County Health, Public Health Nurses. Just something to start with. I was told that this meeting was supposed to be at 9 o'clock, and you all are the leaders of Cook County Health. I actually expect that you would lead by example and have more respect for the nurses' time. This is one of the many opportunities you allow them to voice their concerns, so you can listen to them. And it's been 20 minutes, and some of them have worked all night in a demanding work environment. So for the future, I do ask you to have some respect for the nurses' time and start on time. I am proud to be here in solidarity with the nurses that we represent at Cook County Health in their fight to be treated with dignity and respect. The stonewalling, the delays, and the incompetence of the HR staff working under this hospital system is starting to look a lot like wage theft and union busting. We demand accountability. We demand reform. And yes, payroll needs to cut checks for the 1,200 nurses who are owed years of retroactive wages. We are in the middle of a nurse staffing crisis, and these nurses fought for multiple measures to attract and retain nursing staff with the Cook County system, including retention bonuses, substantial raises, and extra shift bonuses. The system provides half of the charity care in Cook County and cannot be allowed to fail. Yet the inaction of human resources staffing is doing just that. Nurses have been waiting for over 6 months for substantial sums of back wages. I am told that some nurses have been waiting even longer than that for pay discrepancies that stretch back years. Who would want to work for an employer that withholds years of wages? Human Resources is saying that they don't have enough staff to pay the nurses correctly or in a timely manner. Justice delayed is justice denied. I do want to let you know, these nurses, during the COVID pandemic, even when they were petrified to come in to take care of patients who were infected with a deadly disease, in face of millions of patients dying globally, they came to work, and they came to work on time, and they came to work with their passion and compassion and commitment and dedication. And some of them even got disciplined. It is the least of your responsibilities to pay them and make them whole promptly. Incompetence is not an acceptable excuse for failing to abide by the Fair Labor Standards Act or our contract. Those that peddle this excuse should be ashamed, resign in shame. Unfortunately, there seems to be a pattern emerging. These delays are not limited to just back pay, but failures to engage in impact negotiations, systematically failing to respond to the grievances, failure to implement extra shift bonuses in understaffed units, refusing to pay nurses overtime, failure to pay tuition reimbursement claims, managers threatening nurses to prevent them from reporting harassment and safety concerns, and the list goes on.
Pardon me, you have 30 seconds left.
Thank you so much. We will not tolerate attempts to willfully neglect and undermine our union. We have brought these concerns to the board and to the other parties within management, and we demand change now. As directors of this historic public healthcare system, we demand that do all that you can to address the demands of nurses who are day in and out, saving the lives of the millions of residents and lives within the Cook County Health. I do want to let you know we are the fastest, largest progressive union of nurses in the country. They are backed by a nurse leadership around the country and globally. So please respect them. Thank you for your time and have a great day.
The next speaker is Tina Montanez, and as she comes forward, I'm going to do another sound check with Brian Pravel. Brian Pravel, can you hear me? Remotely attending? Brian?
Good morning. My name is Tina.
Madam, hold on one second. Director Garza, are you able to
Yes,
speak?
can you hear me? Yes, can you hear me?
It is
Debbie, can you hear me?
Curtis Haley, can you
Yeah, I'm on the
respond
line.
that you can hear us?
I can hear people online.
Okay, it's something on our end, so we will be working on that. And in the meantime, Ms. Montanez?
Hi, good morning, everyone. My name is Tina Montanez, and I'm a registered nurse in the main OR, and I work the night shift, as Ms. Volt mentioned. I'm here to speak about the lack of accountability and responsibility that Cook County continues to demonstrate to me and my fellow nurses, as well as healthcare professionals, and especially to our patients and our shared communities. As nurses, please, we feel we are overworked, short-staffed, and underpaid. It is not okay that day in and day out, we work extremely hard to provide valuable and necessary quality care to the most vulnerable population. We should not have to beg this committee, our nursing management, human resources, about our retro pay owed to us. We are Cook County nurses. We love our jobs and the communities that we serve. We are urging this committee to listen. We know our worth, we matter, and we deserve dignity and respect to be compensated fairly and in a timely manner. We request that you use your authority and demand Cook County pay us nurses the retroactive pay we deserve and we have been waiting for. We present to you today signatures from nurses throughout the Cook County system demanding our back pay now. Justice delayed is justice denied, and we demand justice for our labor. Pay us what we are owed. Show us that you care so we feel appreciated and supported, so we can continue providing the highest quality care to the residents and families of Cook County. Thank you.
The next speaker is Nancy Alvario.
Good morning. My name is Nancy Alverio. I am a registered nurse in the main operating room, and I work night shifts. I have been a nurse at Cook County Stroger Hospital for 17 years. I am a proud union member of the National Nurses United National Nurses Organizing Committee. I want to address the lack of accountability and transparency from Cook County management, particularly our Human Resources and Finance Department. Their untimely and sometimes no response at all is irresponsible. It affects all of us within Cook County Health, and it especially impacts the quality of care provided to our patients. As nurses, we have stated repeatedly, we are overworked, short-staffed, and underpaid. To delay our retroactive pay that was ratified, now hear this, October 2023, is completely unacceptable. We will not accept this. It's just the county way, or it's just business as usual. It is not okay that day in and day out, we work extremely hard to provide valuable and necessary quality care to the most vulnerable populations. When are we going to sit down and discuss the extra shift bonus program we proposed last year? How long must we wait? We are Cook County nurses. We love our jobs and the communities we serve. We are urging the Cook County Board to listen to us and to take action. Take action now. We know our worth. We matter. We deserve dignity. We deserve respect and to be compensated fairly and in a timely manner. We demand you use your authority and urge Cook County to pay us our retroactive pay as soon as possible. Justice delayed is justice denied. We demand justice for our worth. Pay us what we are owed. Show us that you care, so we feel appreciated, so we feel supported, so we can continue providing the highest quality of care to the residents and families of Cook County.
Pardon me, you have 30 seconds remaining.
And by the way, we heard this yesterday from management, that they're starting to cut retro checks at the end of April from July. This is progress. Yes, it is, but still unacceptable. And we are holding you accountable. Thank you.
The next speaker is Brenda Langford.
Good morning. I'm speaking for Brenda Langford. She could not be here because of a schedule conflict. I'm going to read her speech, and my name is Martise Chisholm. Good morning. My name is Brenda Langford. I am here today to read Brenda Langford's speech. I am here again to speak about the lack of efficiency and standards in the finance and payroll department processes. I am here again to speak about the delays and lack of cooperation in working with Cook County Health leadership. It is bad faith, unconscionable, and unethical for Cook County HR to negotiate a retro pay settlement, but not put processes in place to satisfy the terms of the agreement. Nurses are still waiting for retro pay, which was voted on by the commissioners on October 19, 2023. There is also problems in processing chargeback pay for nurses who want to volunteer for overtime in severely staffed units. Our nurses are experiencing holes in staffing coverage because leadership has been delaying meetings with the union to address the chargeback issues. The inefficiencies in payroll and in leadership are detrimental and negatively impact Cook County ability to provide safe staffing levels and are driving nurses away from our healthcare system, as well as making it difficult to recruit new hires. We are here today to ask for safe schedule staffing, for Cook County to stop delaying negotiated pay for our nurses and to stop delaying justice in resolving workplace issues. Cook County Health talks wanting to have shared governance with its nurses to achieve Magna status. How are our nurses expected to trust management if they cannot live up to their responsibilities and agreed upon settlements or responses?
Pardon me, you have 30 seconds remaining.
What message is CCH leadership trying to leave with nurses? Should we not trust our employers? Should we not expect future bargaining in good faith? Our union has been attempting with CCH for over a year for extra shift bonuses. NLC is seeking to meet with the chief financial officer to negotiate extra shift bonus. We believe it will offer some relief and flexibility in staffing crisis. NNOC is asking leadership to engage in open communication and move forward with meeting our union and nurses in good faith to resolve workplace issues in our healthcare system.
Pardon me, your time
Justice
is up.
delayed is justice denied.
And for the record, Ms. Langford's written testimony is also going to be included in the record and posted on the website. And the next speaker is Genevieve Lewis.
Hi, my name is Genevieve Lewis. I am a frontline worker here at Cook County, and so are my fellow coworkers. We have been waiting for 6 months for our retro checks, and we are questioning why this hospital has not paid our staff nurses yet. We need our money. The cost of living is soaring. Meanwhile, the hospital chooses to prioritize spending billions of dollars on agency nursing staff, yet they have their own staff that they're not prioritizing. It is clear that staff nurses are not important to the hospital leaders, but I am hoping that you see us as important and direct hospital leadership to pay us immediately. Staff nurses have held this hospital together through COVID and chaos. We have ensured quality and safety even when inundated with inexperienced orientees, agency nurses that are inexperienced, and managers that are inexperienced. Our union has also had a proposal for an extra shift bonus on the table since Juneteenth, specifically June 20th, 2023. Why has the hospital not begun to bargain this? I am here to demand these two issues get resolved today and get our nurses paid immediately. We refuse to wait any longer. As you expect your paycheck to be in your bank account on payday, county nurses also have that same expectation.
Okay, the final speaker is actually a virtual speaker, so now is a good time to do a quick sound check to make sure that we can hear them. Ahmed Ganatra, are you present?
Can you hear us?
I can hear
morning.
you, and before you speak, I'm going to do a quick sound check with Director Garza. Can we hear you, Director Garza?
Yes, can you hear me?
Excellent, we can hear you. I think we're all good. Okay, Mr. Ganatra, you can go ahead and proceed.
Good morning, respected board. I am here today on behalf of MMS Diagnostic Center, Inc., an Illinois-based laboratory and diagnostics. who is submitting a complaint regarding county care health plans failure to fulfill its financial obligations under the term of its agreement with MMM. Despite MMM's adherence to the application process and provision of services as an in-network provider, including completing over 36,000 tests to county care members, payments amounting to $6.8 million remain long outstanding, for which interest continues to accrue. Since April 20th of 2023, MMM has engaged in persistent and multiple attempts to reach a resolution, contacting numerous county care representatives and departments without receiving any satisfactory response or resolution. Key points of contact include county care contracting, provider services, county care waiver program, Renee, Tanisha Brandon, Teresa O, Lavonda Deal, Destiny, Michelle W, Rashana, Martha, Dejana Paramore, Joseph Scott with Equity Health, Julia DeMoss, Vince Henthorn, Theodore Dixon, Vashti Brown, Andrew Baranowski, Becca Barrera, Aaron Galiner, Robin Singh, and Dr. Eric Mikaitis. Since April 2023, spanning nearly a year, MMM Diagnostics has engaged in exhaustive communication efforts, reaching out to key figures, including Aaron Galiner, the leader of the county plan, and Dr. Eric Mikaitis, the interim CEO. Despite these persistent and comprehensive attempts to engage with county care and various stakeholders, MMM Diagnostics has yet to receive any form of communication or resolution regarding the matter at hand. Alarmingly, throughout this nearly year-long process, no explanation has been provided by county care for their failure to compensate MMM Diagnostics for the provision of over 36,000 diagnostic services rendered to county care members. This lack of response and resolution stands as a significant concern, underscoring the urgent need for clarity and action. The following documents submitted to the board outline the sequence of events leading to the current concerns, supported by documented communications and agreements. Through this submission,
Excuse me, sir, you have 30 seconds remaining.
Thank you. Through this submission, MMM seeks Cook County Health Board's assistance in addressing and resolving these significant contractual and financial concerns. MMM seeks not only to highlight the unresolved financial, but also to underscore the extensive multi-channel efforts undertaken to engage county care towards a fair resolution. I'm imploring the County Health Board to grant MMM Diagnostics a meeting with Dr. Mikaitis and leadership for a face-to-face meeting to address MMM Diagnostics concerns by March 29, 2024. MMM can be reached at admin@mmmdiagnostics.com to schedule a date and time. Thank you so much, respected board.
Thank you. I believe that concludes our public testimony. Thank you all. I also understand, directors from Dr. Mikaitis and others, that nurses, we appreciate the concern, and we share that. That I understand we've added 2 resources to try to expedite this week, so we're working on it, and you're right. So we appreciate your concerns, and we're addressing it, working on it. Thank you. Next on the agenda are the board and committee reports. The minutes of the February 23rd board meeting are being presented for your approval. Are there any corrections or revisions being made to the minutes? Hearing none, I'd like to entertain a motion to approve item 4A, the board meeting minutes of February 23rd, 2024. Second. Second, thank you. Motion has been made and seconded. Is there any discussion of the motion? Not? All in favor? Aye.
Aye.
All opposed? Thank you. All opposed? Thank you. The ayes have it, the motion carries. Next, Director Bott will now review the Quality and Patient Safety Committee meeting minutes. Director Bott.
Thank you, Chair Taylor. Good morning. The Quality and Patient Safety Committee met on Wednesday, March 13th at 1 p.m. The committee approved the following action items, which are included in the minutes. approved two Stroger Hospital Division Chair initial appointments, approved Stroger and Provident Hospital medical staff appointments, reappointments and changes. The committee also received the following reports, which are included in the minutes: the Operational Excellence Dashboard and the Regulatory and Accreditation Update. Just want to thank the Quality and Safety, Patient Safety team for revising the reports to present them in a new manner, as we've tried to consolidate some of the data. So appreciate the director's feedback and input on those reports. The next meeting of the committee is Thursday, April 11th, 11:30 a.m. The committee did receive a report in a closed meeting, but that report is not expected to be re-reviewed today. So if there are no other questions on the minutes being presented for the board's consideration at this time, motion if there are no discussion, any questions or discussion on the minutes? Have a motion to approve the minutes?
So moved.
Moved and, yeah.
Okay. Second. Thank you. All right, thank you. Yeah, I did. I did.
My fault.
Thank you. Understand. The motion has been made and seconded. Is there any discussion on the motion? Thank you. Hearing none. All in favor? Aye.
Aye.
All opposed? Thank you. Here, the ayes have it. The motion carries. Thank you. Next, Director Ryder will review the Finance Committee meeting minutes.
Mr. Chairman, the Finance Committee met on Thursday, March 7th at 10 a.m. The next meeting of the committee will be held on Thursday, April 11th, 2024 at 10 a.m. The committee considered the following action items, which are included in the minutes. We conditionally approved 14 contract and procurement items. Numbers 4, 5, 10, 12, and 13 are pending review by contract compliance. On the screen, you'll see the contractual requests from the Finance Committee meeting whose fiscal impacts are greater than $1 million, which are highlighted for your information. During the review of request number 5 under the contract procurement items, which was the request to increase the contract with Kaizen Health for non-emergency medical transportation services, Director Harrington inquired whether there's customer survey data available and on wait times, or customer survey data available and data on wait times. Craig Williams indicated that he will follow up on that inquiry. We received and filed grant award related items and received and filed transfer of fund items. The committee received the following reports, which are also included in the minutes: a report of one emergency purchase, revenue cycle transformation plan, and the report of the January 2024 financials. Mr. Chairman, unless there's any questions by any of the other directors, the minutes are being presented for the board's approval at this time.
Thank you. I appreciate it. Do we have a motion?
So moved.
Second. Thank you. The motion has been made and seconded. Is there any discussion of the motion? All in favor? Aye. Thank you. All opposed? Thank you. The ayes have it. The motion carries. Next, we do not have any contracts being presented directly to the board for its consideration, so we can move to the next item, which is, the next item is a report from the interim CEO.
All right.
Dr. Makaitis.
Thank you, Chair Taylor. Hello again, directors. Just wait for the slides. Andrea Gibson is out this week, so we are going to do the one-pager prior to the update. The update will consist of two topics. First, a kind of recap of where we're at with measles, since that's been obviously front and center in the news over the last few weeks, and then to highlight our neurology team and kind of give an update for neuroservices. So we'll start, as I mentioned, with the strategic initiatives. A lot of what we went through in the celebrations is included here. I'll call out some of the other stuff. We are planning a safety and experience week for March 1st. We're currently in an open call for posters. I've had a pretty good response so far, and that's, if you guys are interested in coming to that too, we would love your participation, but it'll be the first week of April. And then our project review board has reviewed and approved endocrinology expansion at North Riverside, so a new service expansion there. And Providence in February actually reached an average daily census of 27, which I know we've been really trying to move up on, so we're very excited about that. And then coming soon, we're reworking guidebooks. Ling and team have been looking to update the books that our patients receive. They're kind of due for a facelift and a bit of a reorganization, so that work's underway. And then rolling out new equipment for language services, and you may have noticed coming in, there's some new wayfinding, little colored stripes on the walls, kind of helping people find their way. It's been a lot of feedback from our patients that they have trouble getting somewhere when they're told what office to go to. So the start of a better wayfinding process. If there's no questions on that, we can move to, all right. We'll start with the measles update. Craig's going to kind of wrap this up, but I'll get us started. So at a high level, just about measles as an infection for anybody. Maybe apologies to the clinical folks, but want to make sure we're all kind of starting with the same understanding. It's a viral infection, takes a week and a half or so. It can take up to 21 days to incubate and actually start showing symptoms. There's a prodrome, usually starts with kind of cough, runny nose, really high fever, and then you get these little white spots inside the mouth. They're called Koplik spots. The rash comes about 3 to 5 days after the symptoms start, usually starts at the hairline and then kind of spreads down the body. And then those who are kind of immunocompromised, young children, pregnant people, immunocompromised, can have kind of wider spread infection, diarrhea, pneumonia, encephalitis. Next slide. So that's just kind of a quick overview of measles as an infection. So measles cases, so at top left, you can see the US last year over this year, 58 cases all year, we're already at 60. And it's actually now, I believe, 62 will end up being the counts. We have 2 more in Illinois. You can see it right. 2023, there were 5 cases, all in suburban Cook County. CCDPH did the work on that last year. We, as of yesterday, we're at 15. This morning, IDPH updated, we're actually at 17 now officially for 2024. Next slide, we can see, and you can see kind of see at the bottom there that ramp up in the histogram. So this is 15 and 3 cases this week. It's actually now 17 and 4, unfortunately. So we are still seeing some new cases. Next slide. So some of the things that we're working on, of course, continuing contact investigations, mitigation strategies. We added measles to the vaccination triage hotline, so anybody can dial that number, 833-308-1988. And it was originally for Mpox and COVID. We've now added measles, so anybody needing measles vaccination, call that line. We'll get them scheduled in a Cook County facility to get them vaccinated. Internally, a lot of resources and education, triage algorithms, testing guidelines, isolation processes, and then specialized training for specialized providers, so nursing, ED, EVS, on how to handle any measles cases. Operationally, there was confirmation that all of our rooms are working, added HEPA filters in ED and ACHN sites, and then ensured that we had supplies available. Next slide. Kind of shifting to the CCDPH perspective, there's one suspected now. As of the slides being put together yesterday, there were no confirmed cases. And then they've been working very closely. CDC has gotten involved now, so there's been a lot of collaborative calls with various levels of government trying to coordinate the response. Obviously, CCDPH is supporting the suburban response. They've ensured our suburban ACHNs have supply to MMR vaccine and have kind of worked through any tracing needs there as well. And they too have done a lot of external communication about measles. And I think our last slide is, yeah, so this is kind of a sampling of all the different communication efforts that we've had. A lot of social media outreach, fact sheets for patients, and facility signage, staff and community kind of resource communication, PowerPoint education efforts, all of that kind of stuff. So, Craig, did you? There he is. Okay. I think the next we're gonna.
Excuse me, I have a
talk
question.
to Craig. Yeah. Mm-hmm.
Just back on one of the points, one of the dots, bullet points just before. The clinics have 50 doses of MMR vaccine for appointment only. What happens if a person walked into one of our clinics, clearly is umpire? What's the process?
So I suspect we would vaccinate. There's some testing that needs to happen. Obviously, we can't vaccinate pregnant people. There's a immunocompromised state there that, it's actually a live vaccine. So, that can transfer to baby. If kids too young, they can end up, can actually cause infection rarely. So there's, in those immunocompromised states, right? So HIV, advanced AIDS, they're at higher risk. So the shift there is then treating when there's exposure, so IVIG or IMIG, to basically give that, it transfers kind of a brief immunity for any infectious risk.
Yeah, two points of clarification. One, you use the term immunocompromised, which I understand, but there are lay people that are probably watching this that don't know what that means, and if you could explain that.
Yeah.
The other thing, measles is airborne, and that's a particular risk. And a lot of people think that if they're in a room and they touch somebody, they may get the measles. But if you're in a room, if you breathe the air that person is breathing, you could get the measles as well. So it's an opportunity to talk about masking and the importance of masking.
Yeah. So it is in fact airborne. That's correct. And unfortunately, when you have someone who is spreading the disease, it can actually linger for 2 to 3 hours in that space. So, here obviously we're looking at, the isolation rooms, it's negative flow, so we're not, blowing any of that air out into the room. So when we isolate appropriately, that air is handled in a way that it's not going to spread. But yes, that is true. If you're in an enclosed space or, a cab or whatever, yes, you should. The primary prevention would be vaccination. So anybody who can be vaccinated should be vaccinated. The 2 vaccine series offers 97% protection. Just having one is 93%.
And the immunocompromised group?
Immunocompromised. So that's anyone whose immune system is not functioning, kind of as would be expected. So you would think, as I mentioned, HIV, advanced AIDS, anyone, receiving chemotherapy, where the immune system is going to be knocked down in a sense. So.
Thank you.
Yeah.
I'm sorry. Are we taking any preventative steps for those that are still coming to check and see if this is an issue before it becomes an issue? Are you doing any screening? Are you checking for the new arrivals coming in such that?
Yeah. So that's part of, I think, what Craig is going to touch on. But yes, we actually, we put an agreement in place at the end of last week that CDPH actually is now allowing us to help them vaccinate. So we're looking to ramp that up, I believe, through this weekend. We're going to start offering that support. And that is kind of the primary intervention there. Anybody who doesn't, convey a history of having been vaccinated from their home country would be offered vaccination. And I believe Chicago has moved now to, if they're staying in shelter, that they're expecting vaccination. So, yeah. So Craig?
Sure, thank you. Debbie, next slide. Hi, Craig Williams, Chief Administrative Officer for Operations and Development. Just want to talk to you a little bit about the operational impact and support we've had as a result of the measles outbreak. So we opened up our command center, incident command, the week of March 11th, and we've had daily calls and situational updates. First call was about an hour long, really level setting everyone on what was happening, the precautions we were taking, what people need to know. On a daily basis, we've been doing 15-minute update calls, just talking about new numbers and any changes. With our buildings and grounds department, we inventory and checked on our system-wide isolation room. So that's extremely important. We have the right negative pressure flow so that because it is an airborne illness, that's not spreading throughout the building. And so we've worked on all that. We reminded staff that we offer daily respiratory fit testing, and we published new information around how to do that. In terms of the support we've been providing for the new arrivals in the shelters, under the leadership of our ACHN team, we have our mobile care coordination team, and we've been partnering. As the measles outbreak happened, we've been working closely with them. And I'd say over the last probably 6 weeks, we've really crafted a strong working relationship with them, and we've been supporting their in-shelter vaccination efforts. To date, what they've asked us to focus on is to do screening and verification of people's immune status and not do the vaccination. So we're really doing that screening up front and identifying the people who need to be vaccinated, and then there's other providers that are providing the vaccination. At the end of last week, we did get an agreement in place to be able to provide vaccination in shelter with our staff, and we're going to start that at the beginning of next week. And what we'll be doing is folks who've had the first shot will be following up with that second vaccination. So we're really trying to focus on what we're being asked to do and make sure that we're working really closely with the State Department of Public Health. Next slide, Debbie. And then I think some of the questions that were asked recently. So how are we managing measles in the clinic throughout ACHN? And so, we mentioned that we have people who can come and be tested, via appointment. There's also the risk of someone just coming to the clinic and having measles symptoms. So we had a, SOP created, and we went through it again with all the sites. And to be honest, it's really operations we should be taking on every day. If someone's demonstrating signs and symptoms of having an airborne illness, how are we segregating them in the exam room? Do we have separate exam space? How do we try to streamline their medical care so they're not exposing the rest of the people in that practice? And so we've worked on that. We've created scheduling and registration workflows. We have screening questions right when the patients are coming in to identify those patients, get them to the right place. We've been able to really ramp up our supply of vaccines in clinics and make sure we have the right PPE in place. And then we've been working with the staff who have individual questions around their immunity to measles and directing them to employee health. The good thing, we have a requirement that you're immune to the measles to work here. But still, obviously in a situation like this, staff get concerned about the work that they're doing. So we just try to make sure that they understand where they are and move that forward. Yes?
What's an SOP?
It is,
So people will know.
yeah. It's basically a procedural policy. So it's a policy and procedure around how we.
I actually think it's just say what the acronym is. That's the
Standard operating procedure.
Sorry.
All right.
And if I can, for the record, I do believe Director Harrington knew what that.
He it's for the general population.
And for the record, I knew too, but I just blanked. Thank you.
Thank you very much. We appreciate it. As I think the staff with this has been, 24/7 on this issue and coordinating so that they can. And remember, we are Cook County Department of Public Health. Right? We have to coordinate with Chicago Department of Public Health, which is where things arrive.
Yeah, I want to make a point that may be lost. No one expected a measles outbreak, so these are costs that were not budgeted.
Yeah.
And it really speaks to how we respond to an emergency, that we do shift funds, we make arrangements to get things done. So money is not the issue right now. We're making sure that we do everything we can to make sure that this doesn't become a real problem moving forward.
Yeah.
Also, it also highlights the issue to address concerns about vaccine confidence, because we went from 2000 to 2019 without measles outbreaks. And the disinformation and concern that the public generally has regarding vaccines, which sadly was only heightened regarding COVID vaccines, really needs to be addressed so that these easily preventable diseases that sadly cause morbidity and unfortunately sometimes mortality aren't an ongoing problem and with our care systems and with our patients.
Yeah, very much so. I mean, if you reflect on our last board meeting, Dr. Hasbrook discussed this issue with almost prescient, right?
Mm-hmm.
And the issues that may come. Now, people like Robinson shaking his hand, and it happens, right?
Yeah, I don't remember if he shared in this forum, but he has mentioned on various calls that there are communities under their jurisdiction that are showing 50 to 70% vaccination rates. And I mean, you need north of 92 or so to have herd immunity. So that's, we're really not there.
It's concerning,
Yeah.
and really helping to understand herd immunity so that those that are immunocompromised are also protected during this.
Okay, well, thank you all, and thanks, Craig. We have one more update from Doctors Ahmed and Dorman on our neurology services.
Please, yeah, there you go.
Thank you. Thank you. So, my name is Jim Dorman. I'm the interim chair of neurology.
And I'm Sahil Ahmed. I'm the interim medical director for neurosciences service line, and I direct the neurocritical care and stroke programs.
So, the first slide being an organizational chart. I know people don't like org charts. So that's just to remind me to talk to everybody here about basically we have a very exciting and challenging time in neurology. So we're a small group, but we interact with many areas of the healthcare system. We have a consult service. Now we have neurocritical care service. We're geographically localized on a neurology floor. We interact a lot with neurosurgery, physical medicine, and rehabilitation. We have our stroke service. We have a neurointerventional radiologist and a neurophysiology lab. So on the outpatient side, we have clinics. We have a clinic presence at the Core Center here at Stroger, Providence Hospital, and Blue Island. As well, we offer a diagnostic laboratory, the neurophysiology lab, where we offer services in EEG, EMG, evoked potentials. These are all neurodiagnostics, and neuromuscular ultrasound. Actually, that last one, we're one of the few places in Chicago that offer that. And instead of us referring out for that, we sometimes get referrals in for that particular diagnostic modality. We have a very dedicated staff of neurology attendings and physician assistants. Next slide, please. So 2023 was a good year. We, like I said, we're a small group, but we're growing. We were able to onboard 10 physician assistants, 7 for the neurocritical care group, and 3 in the outpatient setting. We were recertified as a primary stroke center. We offer telestroke coverage 24/7. We've had the highest number of TPA cases thus far and the fastest time to administer TPA. That's a clot-busting drug that's given for people who have acute ischemic strokes. The big news is the opening of the neurosciences ICU, which Dr. Ahmed will talk about a little bit, and also the continuous EEG monitoring program, which is a great new capability that we have, and it's really taken off. We are now offering vagus nerve stimulators. These are implantable devices. It's sort of similar to a pacemaker, but a wire is wrapped around a nerve in the neck called the vagus nerve, and that's a treatment for medically intractable epilepsy. And there are a variety of neurologic interventions similar to the vagus nerve stimulator. And so in my mind, this is sort of a pilot project, and we're just getting started in being able to offer these sorts of treatments to our patients. We also have PhD neuropsychologists on the program and behavioral neurology licensed social workers. And we're seeing increasing clinic volumes at Providence Hospital and have a cooperation agreement with the University of Chicago residents who come there half a day a week. Next slide, please. So, I said it was exciting, and it is exciting. We're growing and we're offering more services, but it's been challenging. We lost about half of our neurologists in the past year, so we're recruiting and retaining more, and that's like one of our main priorities. There's new equipment and technology bringing us up to date with other hospitals in the region, such as the CT perfusion scan with an AI component that Dr. Ahmed mentioned, portable MRI scanners for the neuro ICU. We're going to initiate telemedicine for follow-up for CIRMAC patients. That's been an issue, and I think that will solve some of the issues with show rates for patients from CIRMAC, transportation, and coverage. We're continuing to work on some software challenges. We have challenges as far as Press-Ganey scores and implementing pathways for new therapies for Alzheimer's disease. Next slide, please. So what's our goal? We want to be the best. I mean, we want to be the best in what we do and to the maximum capacity that we can. I don't think we can fully offer, say, for example, what a university center offers, but I think we can get to like 95% of the way there with about half of the staff probably. So we want to become a referral center, obtain comprehensive stroke certifications for our EMG and EEG lab. And these are things that pretty much we're already doing. We just want to work on getting sort of recognized for them. We do want to expand our footprint at Providence Hospital, both in clinics and with the neurophysiology lab, and expand our outpatient offerings at Blue Island, and do a home infusion service. So there's a variety of specialized medicines which are given, and our infusion center is sort of overwhelmed, but, we're hoping to set up a service where people can get the infusions when it's safe to do so in their house. And this last thing would be a low volume thing, but our level 1 trauma center, there are a variety of new, surgical techniques. They're not new, they've been developed over the past 20 years or so, but, I think that's an area for growth, as we, miss a lot of those patients. I'm gonna pass the mic to Dr. Ahmed.
Well, thank you. Sorry, question before you pass the mic. You said you had a 50% loss of personnel.
Correct.
The basic question is, why?
Well, each person who left, had their own particular reasons. And it's just been a unlucky, sort of storm of different, personal reasons, largely that has led to this, exodus, unfortunately.
Despite that, I would say 2023 was a year of major growth, programs that I think we never had in our health system. We were able to launch because of the vision that was seen a couple of years ago, comprehensively on the neurosciences service line standpoint. Neuroscience ICU is I think the big magnet. It is a program that incorporates lot of actors, a lot of recruitment that happened, neurocritical care, extremely specialized and trained attendings. Myself, I direct the program. We were able to recruit 7 neurocritical care physician assistants who are 24/7 staffing the unit. We are able to accept transfers from community hospitals or anywhere, irrespective of how complicated, how serious they are, directly to the unit or through our ED. We started about 4 months ago, and even without much reach out, we have been getting transfers from these hospitals directly from day one. Okay. In addition to launching the neurosciences neurocritical care program, one other major program which has helped significantly the patient care, quality of care, and improved rates of taking care of these patients here at the hospital and not transferring them out is a program called as Continuous EEG program. That helps in different scenarios, mainly patients who are seriously injured, comatose, who are having seizures, or after post-cardiac arrest. We did not have this technology at our institute in past. It involves expert physicians, it involves technicians, it involves 24/7 remote technology monitoring. And then these informations are relayed to us at the bedside. The point to give all these details is there is a lot that happened in the last 1 year, which is I think taking us to the next stage where we want to be. The third program I would like to highlight is that telestroke telemedicine program, which currently we are offering here at Stroger, as well as at Provident, with plans to reach out to a lot of other area community hospitals where an expert stroke neuroemergency trained physician is available to treat any stroke related problem, any neuro emergency at remote places where they do not have this facility available. Any questions?
How many other hospitals in the area have the ability to do telestroke?
Major centers, I would say that they do have telestroke programs, but to our knowledge, a good number of smaller, relatively smaller hospitals, community hospitals, they do not have neurologists available. And the treatment, the nature of the treatment is it has to be given extremely quickly. You only have few hours to administer this treatment. So even if this patient is eventually transferred to whatever place, if you do not offer that therapy right away, they won't be able to get that medication, and significant disability and health burden continues.
Yeah, you mentioned there was some problems with the Press Ganey scores. I don't want you to elaborate now, but maybe you could bring back information during one of the Quality and Patient Safety Committee meetings so we get a better idea of what areas you're working on and where the problems are.
Sounds good.
Can I ask a question? Please. So, the quality question, in follow-up would be good to know what quality metrics you're tracking. And, we can follow that up, per Director Harrington. The other question is on the focus areas in the future. Is there a budget, impact or consideration that the board should be thinking about?
The, budget impact, we have, we're working on different PID requests, and, I'm not sure exactly when y'all see that. But, to become a comprehensive stroke center, that would have a definite budget impact, because we'd need, 24/7 coverage, a certain the type of doctor who does the endovascular procedures, the catheter-based procedures. The rest of it, we do need to sort of, in order to expand our footprint to Providence and Blue Island, we have to stabilize our personnel issues. We need to recruit, retain neurologists to be able to expand. And the, really the peripheral nerve surgery, that's just a coordination of care issue. And the home infusion service, we're gonna work on a pro forma for that and get that to you. But that will definitely have budget implications. But you know, that's things like neuro care and infusion services are for neurology departments. What keeps steaks in the freezer?
To add on a quick comment to that question, IR, interventional radiology, which neuro-IR or this procedure Dr. Dorman was explaining, is like an area where we had lacked robust presence, which is kind of like a focus in last like some time by our medical leadership, and probably would give us like some like fruitful results in coming months in terms of recruitment.
Thank you. Any other questions? All right, if not,
Thank you very much.
that concludes the report.
Actually, it's good to see, service line expansion is one of the key things, and service line expansion requires investment. Yes.
I have 1,000 questions. I'm familiar with the process. My question is, what type of an impact can we have from the human perspective as well as from the business perspective? Because I know it can save lives and it is extremely needed, but I don't hear or understand the case for how we're going to expand, how we're going to stabilize our personnel, how we're going to generate revenue that would be sorely needed, and then how count the lives. Because we know it can have an impact, but let's prove the case. That would be interesting to me, to really see that impact, because I think the opportunity is great, but if we can quantify it, that would be very nice.
Okay. Especially as we ready to do our annual budget process coming up.
Let me think about how we can roll that into kind of a broader population health report I'm hoping to give next month, and maybe we can kind of, potential lives impacted or, we can think about how we can do that.
I mean, if we're saying private strategic plan and service line expansion, we have to understand all of both the people as business and physical capacity.
Yeah, and I think there's also a component of, we have to be strategic as well about where we're focusing and what we're doing, right? It can't be everything all at once, right? That's not good, right? So, and that's been, I think, kind of the discussion over the last few months has been, all right, how are we a little more strategic and discerning around where we're going to focus and how we're going to expand, right? And then understand that there are things that come behind that, right? Like, but how do we focus and really, do these 3 to 5 things for the next year or 2, right? And then move to the next, right? So.
But it does also give very good feedback to see in recognizing that utilization of TPA decreases the likelihood of chronic morbidity that also has a financial as well as personal cost. And the general public and our population being able to see that, utilizing those early interventions can certainly help to respond not only to your answer, Director, but also the general public in our moving forward in these areas.
Absolutely, yeah, and it's kind of creating that receiving transfer center, right, with all of those things, so we can help those in the community, right, to bring them in. Totally agree.
And where it can become really interesting, if you show the impact and then how you are starting to expand the life cycle here, because this, I think, Director Harrington loves to talk about the Tale of Two Cities. I think that was him. And see how we actually can have an impact, and this surely can move the needle to some degree.
Absolutely. No, I agree. Exciting, but also challenging. The next items are the informational reports. We'll start by receiving the Employment Plan Office semi-annual report presented by Kimberly Kraft, followed by the Managed Care and Human Resources Committee metrics presented by Erin Galena and Carrie Promet-Folk. The metrics are being presented directly to the board as those committees did not meet this month. You want to stand, Kimberly, versus sit? Okay.
Sure.
Perfect.
Good morning,
There you go.
everyone. Again, Kim Kraft, I'm the Employment Plan Officer. So before I jump in, I know that Dr. Makaitis, this board, and my colleagues are all very aware of what the employment plan is and what the function of the employment plan office is. But for the benefit of the broader public audience, I would like to take the opportunity to quickly go through both of those things. So first, what is the employment plan? It is a manual that contains the structured processes for hiring and other employment actions that are applied system-wide. What does that plan do? It prohibits discrimination. It contains proactive processes and procedures, meaning that they prevent the opportunity for discrimination. Requires transparency, meaning that we demonstrate compliance with the applicable requirements and our lawful decision-making through the documentation generated in our employment actions. And the plan does also require that we honor our collective bargaining agreement. So sometimes this does result in employment actions that are a blend of both what's in the employment plan or the applicable supplemental policy, and then what in addition or different collective bargaining agreement requires. And then what is my office? What do we do? The Employment Plan Office is a team of Cook County Health employees who oversee and support compliance with the employment plan. How do we do that? We prepare plan-related training materials, and we train employees at all levels on what those requirements are. We observe and audit employment actions to assess for compliance. Sometimes this involves kind of jumping in and helping course correct. But we're really looking to see how things are going, leading into the next thing, which would be developing strategies and procedures to achieve compliance. So maybe we need to update our training, maybe we need to develop additional job aids or resource materials. So we would identify those things through our observing and auditing. We investigate allegations of non-compliance with the employment plan, and where appropriate, we are issuing incident reports at the end of those. Where we find non-compliance, we would include recommendations to remedy and prevent recurrence. We do refer reports of political contacts and unlawful political discrimination to the Office of the Independent Inspector General if that gets reported. We do maintain the direct appointment list. And then we also issue semi-annual reports, which cover employment plan-related activities for the preceding 6 months. So that's why I'm here today. I'm here to present a summary of the EPO 19 semi-annual report that covers the period from July 1st, 2023 through December 31st, 2023. So the full report will be placed on the website. Next slide. Okay, starting with what's new. There's been a lot of progress since the last time I've been before the board. The first thing is, as you know, the accelerated hiring process that was piloted for nursing, that was approved in August and implemented starting at that time. Annual training, that training is required to keep us in compliance. So we currently are well underway with our annual training. Optimization, I've spoken at several past meetings about a lot of, as you know, HR has been working on optimizing as much as they can the hiring process, and a lot of times that has really benefited us in what we do. So one of the things that we're really happy to see is the newest tool, which is the HR Position Status app, which really allows us easier access to a lot of information that comes from multiple different sources. So happy to see that. Also Salesforce within my own department. We now have that for our investigations, which is wonderful, and we are currently exploring how we might be able to use Salesforce for other things that we do in the employment plan office. Beyond that, oh, sorry, I'm still going, that's okay. Employment plan staffing. So, you know, we were impacted by, you know, the pandemic and the Great Resignation, the way other departments have been. So I've reported in past meetings that we got all the way down to 2 at one point. Happy to report that we are now back up to 4. As of late August, we welcomed Bianca Willis, the department's analyst. She came on with, you know, great talent and energy, and she's been a valuable addition to our office. And then I reported in past meetings that I was interested in having the website page or a page on the CCH public-facing website that would be user-friendly, that would describe the employment plan, the employment plan office, and just make those resource materials readily available. And so that was finalized and implemented in the reporting period that's covered. Next slide. Okay, so one of the things, as you know, we do is we investigate allegations of noncompliance with the employment plan. So about a year ago, when I presented to you, I mentioned that we carried a significant backlog of investigations, you know, partly due to some short staffing, and then we had multiple competing priorities, you know, with the pandemic and Great Resignation and things like that. The board asked that we prioritize kind of addressing that backlog of investigations. So that has been a significant focus of ours since that time. So as of the beginning of this reporting period, so July 1st, we held 78 open investigations. During the 6-month period, we did close 46 of them, brought on 14 more, and currently we're pending at 46. So we're still working on that. We did have 2 incident reports that were issued during the reporting period with findings and recommendations. Some of those recommendations have been implemented already, and some are still in progress. Next slide. Okay, so now I just have, there's several hiring processes that we have here. And so how they're handled are completely different from process to process. And so I've gotten these broken down between the appointed positions and the non-appointed hiring process positions. So for the appointed positions, the volume is pretty low. We look at all of them. And so for medical staff and executive assistants, we only had 5 medical staff packets come through. We did not identify anything of concern. 1 executive assistant packet, 1 concern, and then there were 19 direct appointment packets. There were 2 where we had to engage in some conversations regarding them, and then 1 ultimately resulted in an incident report. There were recommendations, and 1 is really geared at preventing, you know, providing additional job aid and preventing recurrence there. Next page. Okay, so for our non-appointed positions, we've got the revised temporary hiring process and the advanced clinical positions. We did DTH reviews for both of those. And what a DTH is a packet that's generated at the end of a hiring process that will include everything, the documentation from everything from the posting all the way until the decision to hire has been made. Decision to hire packet allows us to really get in and evaluate all steps of the hiring process. And so what we did identify in revised and advanced clinical positions is that there was some documentation with missing signatures, and in both hiring process types, there were 2 posting errors each. So we've already updated our training deck to further reinforce the posting verification process, and hopefully those types of errors will be eliminated. Accelerated hiring, so that was the new hiring process. So what we did for this one, we had agreed to a different manner in which we received the documents for accelerated hiring, just to kind of save time given the accelerated nature of it, and just it's a different process, and so the paperwork that gets generated is a little bit different. So rather than having packets delivered to us, we agreed to go into HR's records and look at them there. So what we really wanted to do, at least for now, is just to go in and make sure that the structure is in place so that it's sufficiently auditable, and spot checking in files to see if the document's being maintained. So we did see some instances in which, you know, the files were empty. So we do have to visit that, and then we do also have some recommendations for just kind of structuring the documents to support auditability.
Kim, excuse me, question here.
Yeah.
You say looking at documents, is this all manual? How much of this is automated?
For the decision to hire?
Yeah, and the review of the documents and signatures. I mean,
Yeah, so for now, there's that new, one of the tools that was developed recently through the automation is this decision to hire portal. So
Okay.
for most hiring processes, everything gets uploaded and there's a link and you can click a link and look at everything. And so that's been fantastic. And so for accelerated hiring, it's a little bit different. You know, we wanted to avoid the time associated with that. And so those folders are just kept on the shared drive.
that's Robinson. I see your face.
Sure.
So the accelerated hiring is a manual process. The other hiring is automated.
The process by which we access
Right.
the documents at the end is automated.
Okay.
So they get uploaded to a central repository for those, yeah. So there is automation that's been built in, so the same types of procedures that apply for other hiring process would apply for accelerated. So that you're gonna get applications through Taleo, but at the end, those documents, they have to be collected and filed in a particular way. And so with those other hiring processes, there's a portal that we look to. For accelerated, we're going to an internal drive.
Okay, all right, well, the next. Huh?
No,
Yeah, this comes to next. I see your faces. Okay, keep going, thank you.
I'll keep going. Okay, and so that's basically all for that one. And then moving on to the non-appointed positions. I'm sorry, the hiring fairs, still non-appointed. So hiring fairs, as you know, we utilize hiring fairs monthly, pretty frequently. There's been a lot of hiring done through those. It allows for the day of fair contingent offers, so that's a wonderful thing. There is a lot of planning and coordination that happens on the front end between HR and the hiring department, and that process has been very smooth. So we have to give a lot of credit to the project management team in HR for keeping that moving. And since she's here, we'll acknowledge Dawn Brown. She does a really great job of keeping that moving. Some of the documentation, you know, we observe these a little bit differently because there's so much volume. So, you know, sometimes we'll pop in and look at things, you know, observe things in person. Sometimes we'll look at, in this case, we observed 23 decision to hire packets, and then we'll just do spot checks of teams, which is where the documents are maintained for this particular hiring process. And so in the past, you know, one of the concerns identified was with the consolidated rank lists, which are generated as a result at the end of the process for those, you know, maybe our departments have identified people for hire, even beyond those vacancies that we have available on the day of the fair. And so that results in a ranked list that we can revisit later on as additional vacancies become available. And so from there, we did identify, excuse me, some missing signatures, and there were some sorting errors and some missing data. So we did discuss that with the leadership team, and those we're confident will be addressed. Moving on to our next page, please. Next slide. Thank you. Okay, so we also observe a lot of employment actions that are not related to hiring. And so just quickly running through the supplemental policies that we have observed. Interim assignments and interim pay are one thing that we look at. I've mentioned in some past reports that this is an area that we've had some concerns with, mostly because the two policies, interim assignment and interim pay, are, you know, they're meant to work together, they're incompatible. And so that is something that has been, on the radar and has been a plan for a policy update. And it's my understanding that, that will be happening very shortly, with additional, resourcing in HR now available to assist with that. Discipline. So we also look at discipline. There is a team in HR, so we access their drive where they receive, HR, the discipline packets from the department. So they're reviewing these things as well and addressing them along the way. We do our own reviews as well, maybe not necessarily at the same time as HR. But what we're looking at is to see if the paperwork submitted demonstrates compliance with all of the applicable requirements throughout, whether it be the personnel rules or the supplemental policy itself. I identify any time that there are administrative errors, because those are important too, for HR's maintenance of the files, as well as anything more significant in the file, maybe missing approvals that are required in the process. Maybe there's PHI, yeah. Oh, sorry.
Yeah, what constitutes significant?
Okay, yeah, so a more significant finding would be, excuse me, where maybe there's approvals required in the process. Certain levels of discipline HR would have to approve. And so if we don't see the signatures that would verify that that has been done, we would raise that as a question. Maybe what we're looking at is a draft and, we need to track down the final. So in those cases, we'll bring those to HR's attention. Like I said, they're reviewing them on their own, but we'll address those to make sure that anything that's significant that would have to be addressed will be addressed. Sometimes it's just a matter of maybe the document was created and just never submitted to HR, or it could be a more significant concern in that it was never created in the first place, which would demonstrate, violations with applicable requirements. And then, as I've mentioned in the past, the HR business partners, that's a role that's going on about 2 years now. Those are HR liaisons to our leaders and to our employees to help. They're really great at helping navigate through the disciplinary process. A lot of times there are collective bargaining agreements that also apply, and so these HR business partners are very valuable in helping them, our leaders, navigate and make sure that they're also honoring all collective bargaining agreements. Okay, layoffs. There were 3. We didn't identify anything of concern there. Training opportunities and overtime. So these policies are a little bit different than the others in that there's not a form that's filled out every time with NPCC's no political consideration certification collected, which is where for other hiring processes, our leaders are, every time they make a decision, they are signing a statement that they have not taken political reasons or factors into account. With training opportunities and overtime, that's handled via a survey that is sent to the leaders twice per year. So the most recent ones were due December 15th. We sent the NPC certifications to 268 department heads system-wide, and currently we just have 12 outstanding. So we will continue to follow up on those. Reclassifications, there were none reported for this hiring or for this particular period. Next slide, please. Third-party providers of HR services. So that particular policy just provides for us for the ability to contract with, through contract, get assistance with recruiting processes. And so there was one new contract during the applicable period. And the policy covers, the request process, the approval process, the training that's required, NPCCs that are required. For example, anyone coming in through contract would have to attend the same training and follow the same rules that our employees would. And so we did not find any concern with the contract itself. And pending right now, it's a relatively new contract, so we're just making sure that we have identified everyone who is coming on board to provide those services and making sure that they have all required training. Grade 24 salaries, up through grade 23, we are on a salary schedule for those. Grade 24 are more the higher level professional positions. They are more so dictated by, things like market conditions. And so there's separate paperwork that comes relative to those that identify what's been considered and what the salaries are. And so we reviewed several of those over the past reporting period, and we just have made a few new recommendations just to kind of increase the analysis and the paperwork to provide a little bit more transparency. Next slide. Okay, so what is coming in the future? I know I've spoken in past reports about several temporary amendments that have been made to, and permanent amendments that have been made to the employment plan over the past couple of years. They do have to be in the employment plan that is visible to the public on our website. And so, over the years, because we were, in a pandemic and the Great Resignation, there was a lot of, urgency to get these amendments made. It was more of an outline process when they were presented and proposed. So we really do need to get them documented in the plan as soon as possible to provide that transparency. It's my understanding that that's coming very soon. Website updates. Have spoken in the past about the need for job descriptions on our website, all of our job descriptions, which is required. We're not quite there yet, but I did confirm that this is something that's, the organization is working on with a lot of effort to get that done. Quarterly reports. There is a requirement in the plan that HR produce quarterly reports with certain data included. The current template is missing some fields, and so we've been working with HR to get that updated. There are some systems, involved in kind of getting ready access to some of that information. So that is also coming shortly. In terms of policy updates, there will be a continued review of the employment plan to modernize it. That'll be taking place this year, as well as some updates to supplemental policies, and then training, of course, as the employment plan is updated and as the supplemental policies are updated, we'll have to update the training materials and job aids that go along with those. And that is all I have, unless anybody has any more questions. If I can clarify any more about the digital questions, or maybe Gary can answer that better than I could.
Thank you. Galena?
Thank you, Chair. Good morning, Directors.
Good morning.
Good morning. So we'll run briefly through our standard metrics that we show. Starting first with membership, the health plan as of March is at 440,000 members. This is an increase from the prior month as we continue to take on in phases the healthy benefits for immigrant adult population that's transitioning into managed care. The next slide shows our market share data. So this data is through December, so still a little bit delayed, but you can see we're holding at that 32.3%. Again, we expect this will start increasing as this looks forward between January and April, given the additional population that we're bringing on into the plan. The next slide shows our trends versus the overall Cook County Medicaid managed care market trend. You can see that we're tracking pretty much right in sync with the broader impacts that are happening in the market. You can see the peak coming out of the pandemic and the start of the redetermination process that have been paused, that's lowering membership across the board. Again, this data is only through December based on what's been published by the state, but as this looks forward, you'll see that we'll have a swing upward January through April, and then likely we'll resume some decline over the course of the next few months until the initial large wave of redetermination ends. The next slide shows our membership comparison to budget. So red bars are actual, blue bars are projected based on budget. Again, you can see the month-over-month growth that we have experienced from January through March, and that's really driven, again, by taking on the healthy benefits for immigrant adult population. The next slide shows our redetermination data. We're continuing to see we're ranging right between the 84–85% successful redetermination rate, which is great, continues to exceed what our initial expectations were, and we're continuing our full-scale efforts around outreach and engagement. And we continue to see, in addition to this, well more than 90%, usually between 92 to 93, 94% of individuals are submitting their paperwork back. So we're seeing people not lose coverage because they just haven't completed the process, but there are some individuals that are no longer eligible because of other changes, either to income or other statuses. The next slide is our operations metrics. These are all operating within SLAs. A couple call outs here is just you can see the call volume has jumped heading into January and February, and that's I think a function of a couple different things. There's open enrollment, where a majority of our individuals go through that process late in the year. This is also when our choice campaign is heavily out in the market, and so that does drive some call volume, which is great. And then of course we're also bringing on the new population, so we're seeing an uptick in calls and of course redetermination as well. Next slide shows our utilization performance. You can see this is comparison to prior periods, so red versus blue, red being prior period. So we continue to see relatively stable utilization trends. You can see some of the projections in the light blue shading are starting to project some slight increases versus the prior period, and that's again due to redetermination, as we tend to see individuals with less chronic disease or healthier statuses that are less likely to redetermine. So the population that is left in the plan, the acuity tends to increase. The next slide shows our claims payment trends. As we had mentioned to you heading into the end of the year, we tend to peak with claims payment timing as the budget rolls over, and then we start to see that continue to drop back down towards our normal ranges. By the time that you see this data next month, we're pretty much back at the 30-day mark at this point. So you'll see that flow through here in the next month's data. And then our final slide just represents that via table, so you can see most of that impact is in that 30 to 60-day category. And again, you'll see that drop down to fairly minimal amounts by the next report. And with that, I'm happy to answer any questions.
Thank you. Carrie, thank you.
Good morning, everybody.
Good morning.
These are our usual metrics that we report on, and as you can see, we, after the first full quarter of the year, we have filled 281 positions with a net new of 57 positions. 195 of those were external candidates coming into the organization, so internal movement of our staff. Our time to fill, and that's an offer acceptance ratio that we're getting right now at around 70%, which is pretty stable from what it was last year. Right now, our time to fill after the first quarter is 126 days. We did expect an uptick in December. There is a temporary freeze in changes that can be made for our requisitions with our partners downtown at the budget department because they're transferring from one budget year to the next. And we expected a slowdown when that occurred, and we did see those numbers slow down. As well as because of that, there was an impact delay when for people who have been going through the onboarding process and needing to have some of their medical and certifications reassessed. And then after that, then they were onboarded. So that kind of a delay, we expected an uptick for quarter one, and we're working on some measures to make sure that that trend does not continue. Next slide.
So So we should expect it to drop back down to the 91, 92 category?
I don't think we'll see an instantaneous drop to the 90s. We also, and as my report will show in a couple slides, the pilot for the accelerated nursing program ended in the beginning of February. We are kicking it back up again next week, and so we expect that will also trigger shorter time to fill times as well. However, since there's that 1 month plus delay there, the time that it takes to get it back down to the numbers we were seeing at the end of the year is going to take a little bit. But we do expect by the end of the second quarter that we should be seeing numbers back in the 90s.
Can I ask this, Carrie, and I don't mean to be disparaging this way, do our partners working on the other side sensitive to the impact that these types of delays have on that system getting people in?
I believe they are, and they have this, the other agencies have this exact same impact, and that they are, taking that into consideration as well. So it doesn't just impact us, we just happen to be a bigger number for everybody. All right, so this shows our separations for the first quarter of the year. As you can see, year over year, the top bar on that far left graph shows that we have far fewer separations in quarter one, which is a great indication that not only are we filling our positions, but we are retaining our staff as well. The bar graph on the right, if you look at the navy blue bars, those show for fiscal year 2024 of the first quarter. And as you can see, the retirements are a little bit lower, not much, and we would expect that that's not going to decrease significantly year over year as we do have our aging workforce. However, the resignation numbers you can see over the last couple of years have significantly gone down. And we believe a lot of that is due to our retention efforts. Next slide. This next slide shows our turnover rates for the past years, the same quarter. And as you can see, we are just as low as we were in fiscal year 2018 at the same time, which is pre-pandemic and good, and we are continuing to decrease. If you look at the last couple of years, even from last year, we've gone down a couple of points. However, when we look at the U.S. Department of Labor, their monthly retention rate shows that it's around 3.2, and so we're even below the monthly national average, which is good as well. The next slide. And the final topic is that accelerated nurse hiring process that we began last fall. The process, or the pilot, ended on February 6th, so the very beginning of February, and these were the numbers we had related to that process. We had 411 offers go out with 231 accepted. As of the end of February, we had 119 of those have started already, and that's just due to people needing to give notice to their employees, getting through the onboarding and orientation processes, and starting with their department. As you can see at the bottom number is the number of interest. So last report I gave you that we had a 74-day time to fill while we were utilizing this process. In the month that we stopped using this process, our time to fill for nursing went up to 85. So we do see that there was a significant impact on time to fill with this process. And that's why we are kicking up the pilot again starting Monday. And we have another 6 months to assess. We've made some tweaks based on lessons learned in the last 6 months. And we're hoping that those new processes and this extended pilot will take hold and give us even better results. And if so, we're going to make some permanent changes to our employment plan related to those.
Question. The acceptance rate, that seems to be lower than it was last time reported.
That was because the numbers were still being crunched as people were either accepting or thinking about it. And now this is with all of the entire program of that 6-month period, all the data being accounted for.
Okay, thank you.
You're suggesting that this is still a pilot, although there's been positive data. What else needs to be tested in order to then integrate into business process?
So we only tested it with one type of role in the organization, and now we're expanding it to multiple types of clinical, and then soon in the next couple of weeks, we're working through expanding it to some non-clinical roles, and we want to see the changes that might require us to make to the processes we're using before we make a final permanent change to the process.
Thank you.
Yes.
Yeah,
Director Harrison.
yeah, I see that the total acceptance rate and decline rate is at 92%, so that 30 pending makes up the 8%.
Yeah, and then a lot of that is due to some, data error or entries still not being in the system for the, you know, the finality of it.
Thank
you. Any other questions? That concludes my report.
Thank you very much. Thank you all for the report. We appreciate it. At this point, the board will be going into closed session. Action is not expected to be taken in the open session after the discussion in the closed session. Therefore, I'd like to entertain a motion to go into closed session pursuant to the following exceptions to the Open Meetings Act, 5 ILCS 120-2 C1, 2, 11, 12, and 17. Do I have a motion?
So moved. Second.
Thank you. The motion has been made and seconded. Madam Secretary, please take the roll call vote on the motion.
Roll call vote on the motion to go into closed session, aye or nay. Director Bott?
Aye.
Director Curry?
Aye.
Vice Chair Deere is absent. Director Garza?
Aye.
Director Harrington?
Aye.
Director Ryder?
Aye.
Director Robinson?
Aye.
Director Sorrell? Aye. Director Webster Cross?
Aye.
And Chair Taylor?
Aye.
You have 9 yeas, 1 absent.
Thank you. The ayes have it. The motion carries. We'll pause to have a room. I'd like our council and board secretary to remain. All others online and in the room, thank you for your time. We appreciate it. Have a great weekend.